So I'm Martin Rolls. I'm a clinical oncologist in Consultant Hospital, and I was with the chronic diseases, long-term conditions group. And the thing that we really focused on was empowerment of patients to take personal responsibility for their condition and to manage themselves as much as possible. This isn't a new thing, but I think it's something that can be definitely enhanced, and it might have quite significant benefits. There are a lot of patients with chronic conditions. We recognise that there's a spectrum, and some patients are chronically quite ill. Some patients are really completely well most of the time, but may have an occasional exacerbation of their condition. So some patients with asthma, mild asthma or COPD, or even some patients with cancer may be well for many years. And a lot of these patients we're still seeing on a very routine basis in hospital, and to some extent we medicalise their lives when it's not really necessary. And for those patients that are basically well and who are able to take responsibility for themselves, what we want to do is educate them, and so that they understand how to manage their own conditions to reduce the chances of exacerbations, for example, managing their chronic diabetes or their asthma, so they have less exacerbations of their conditions, less likelihood of problems. But if they do have problems, then we want them to know how to access the appropriate care. Rather than end up in accident and emergency, they will have defined pathways, have certain key workers or CNSs that they can talk to, and so that they, even though they may not be being followed up on a routine basis, they can rapidly get back into the system should they need it. Now, a lot of these cases are being followed up routinely, and it's a sort of historic thing, and this sort of regular follow-up doesn't necessarily have an evidence base, in that it may not improve overall health or overall survival, but yet we're doing it. So I think there also needs to be a critical analysis from our point of view as physicians and hospital managers about whether we can reduce our follow-up lists. And hopefully by doing all of this, it has two benefits. First of all, the patients become more independent, have better quality of life and a feeling of control. One of the problems with regular hospital management and medical management is patients there's a tendency to sort of have a passive acceptance of your condition rather than something that you can take responsibility for and manage. But also, if patients are sort of independent in the community and only access when appropriate, then it potentially frees up hospital resources. So, some of the clinics which are full of routine follow-up patients where we rarely make any changes to management or intervene can be freed up and will allow more time for management of other patients who do have immediate problems or who can't manage themselves. We also recognised as a group that some patients would need to be risk assessed. Some patients are clearly vulnerable, or they are too unwell and are not able to manage themselves, and those patients do need to stay in the system on a routine basis. If we're going to do this wholesale, it does represent something of a shift in the emphasis onto the patient. So there is a change in public perception, and there will need to be quite a lot of public education.